Okay, welcome to Learning Module 2, and this is the interactive lesson 2.2, and I will be talking about pathophysiology of the central nervous system, and we're going to start by talking about the pathophysiology of seizures. Now, before I get into talking about seizures themselves, I wanted to talk about the EEG, or the electroencephalogram. Now, the reason why this relates to seizures is because for the past 80 or 90 years, this has been the main way of measuring and detecting seizures objectively. So, what is the EEG? The EEG is similar to the EKG in one sense. They're both measuring the waveforms, so the electrical waveforms of action potentials as they move in a direction. Now, for instance, okay, so this here is a front-on picture of the head. So you can imagine here, this is a person that you're looking at, and this is their eyes and this is their nose. So what you're seeing here is a sagittal view, so you're seeing sort of the inside of their brain as if the brain was sort of sliced in half. Okay, now imagine that an EEG, when you're measuring an EEG, you usually put a collection of electrodes all over the scalp. Now each of these electrodes measures the movement of action potential. So the movement or propagation of an action potential from one direction to the other. So this, for example, if we are looking at the action potentials, if we are looking at the electrode, this electrode here, it is going to be moving. It is going to be measuring action potentials as they move towards it. So anything here, let me change the color of my pen here so you can see it better. Okay, so then anything that is moving towards it will cause a positive deflection. So this is the picture of the EEG. This is more positive, this is more negative. And so if there were action potentials moving towards this electrode, then, and this is 0 here, then it will make a positive deflection of the waveform. And if there are action potentials moving away from that electrode, this measurement will deflect to the negative side. Okay? So anytime you see a waveform like this in an EEG, this means there are action potentials moving towards the electrodes. This means the action potentials are moving away from the electrodes. Now, this electrode isn't measuring just one action potential. There are a whole bunch of action potentials. And what it is measuring is the average of all the movements of these action potentials that are taking place in a given moment. Okay? So this here we're actually looking at time. And this here we are looking at voltage changes to the positive or negative side. Okay, so say at any given moment, at one given moment, there are action potentials traveling in all different directions. But what this is going to measure is it's going to actually measure the average of all of these. And this average in three-dimensional space is called a vector, if you remember in physics from your physics day. So it is actually looking at the vector, which is the average direction of movement of the action potentials in a three-dimensional space. So if you take in any given moment, if you take a whole bunch of all the action potentials that are happening near this electrode, if the vector is pointing towards that direction, towards that electrode, it's going to cause a positive deflection. And if the average is pointing away from that electrode, then it's going to cause a negative deflection. And if the if it's pointing, if the average is neither pointing towards or away from it, it's going to end up in the middle. Okay, so whenever you're looking at an EEG, you're looking at the average of movement of action potentials in either towards or away from that electrode at any given moment in time. And then the EEG printout is going to be printing the movement of those vectors or of those action potentials over time. Okay, so I wanted to start here with a clean slate. So here I'm going to draw a typical EEG. So let's say we're going from 1 second to 10 seconds in time. And we've got our positive deflections and our negative deflections. And we've got a waveform that looks something like that. Yeah, that's a relatively normal waveform. So we're still looking at this electrode right here. Now, why is there this relatively rhythmic waveform that occurs? Well, interestingly enough, down in the thalamus of the brain, we actually have pacemaker cells that are setting out rhythmic beats of action potentials. So, sending out in a specific rhythm, okay? And this rhythm is measured in what's called hertz, which just means the number, I believe it's number of waves per second. And these pacemaker cells are sending it out in a very specific rhythm. Now these rhythms change from time to time. Sometimes the waves are very, very fine and very close together. Sometimes the waves are nice and slow. And how fast or slow they are is controlled by these pacemaker cells, and they are related to different brain states that we are in. And we sort of, people have noticed that there are different frequencies of waveforms that occur, and we've come up with names of them like alpha, beta, and theta. So these are all different waveforms and these are all normal waveforms that can occur depending on our state. I know that alpha waveforms are usually indicate that the brain is alert. Beta, no, actually it's the other way around. Beta means that it's alert. Alpha, and you don't need to know any of this, but I just want to give you some examples. Alpha means that you're sort of in a trance-like relaxed state or very focused. And then I think there's a delta that that occurs in deep sleep. And these are all, again, sort of controlled by these pacemaker cells. So these are just sort of pulsating waveforms that occur. Now, you know, the thinking that occurs in the brain are happening sort of in the midst of these waveforms. And certain types of thinking seems to occur better in different types of waveforms. So this is not the work that the brain is doing. This is just the brain in its, you know, sort of background state. This is sets sort of the background tone for the brain, and then the work that the brain is doing when you're thinking thoughts or seeing things or hearing things. There are extra action potentials, but they're relatively small compared to sort of the background noise of the brain. Okay. So this is what you're measuring when you're measuring an EEG. So this here is an EEG of a patient that is having a seizure. And you can see this area here is a normal EEG from here to here. But this area here, you can see things change significantly in the waveforms. You can see the waves are much greater amplitude, and this represents that the action potentials have a lot more energy behind them. Now, so this brings me to the definition. I think it's easier to visualize it sometimes than it is to just hear it. A seizure is a sudden, means it starts very abruptly, and transient, that means it has an end, alteration of brain function that's caused by an abrupt explosive, meaning a lot of energy, which is represented in significantly elevated amplitude of the waveforms, and disorderly discharge of neurons. Okay, so we have sudden but transient, explosive, and disorderly. So that sort of defines the waveforms that we see in an EEG. All right. So the EEG makes it, I think, fairly easy to visualize. You can see this normal background waveform, and then this sudden change where the amplitude gets very, very great because of the sort of explosive energy behind the surge. And this is all being this here is a generalized seizure because you see it in a whole bunch of electrodes. So pretty much all the electrodes are demonstrating the seizure. So I'm going to talk about the types of seizures. A generalized seizure is a seizure that involves both hemispheres. So you're going to see it in electrodes on both sides of the brain. Okay. And we can have a primary generalized seizure. That means a seizure that sort of starts itself. I'm sorry, let me say that again. A primary generalized seizure is one that starts out generalized. So it starts out starts simultaneously in both sides of the brain. So if we have our brain here, the seizure is going to start here and here at the exact same time. Okay? Now, the next type of seizure that I want to talk about is a partial seizure. And with a partial seizure, it's only going to start, these are the two hemispheres of the brain, it's only going to start in one hemisphere. Alright, and it's going to also end in one hemisphere. A generalized secondary seizure, here, let me use a different color here, will start in one side and spread to the other side. That is called a secondary partials. A secondary generalized seizure. Secondary generalized. Okay, so partial stays on one side of the brain. Generalized can either start on both sides or end up on both sides. Okay, so what would a partial seizure look like on an EEG? Here, let me scoot over here and I'll show you a partial on an EEG. Okay, so if we had an EEG here, we would have, maybe a normal waveform continuing here and here, but this third waveform will have some seizure activities, and maybe this other waveform will have some seizure activity, but all the other ones remain the same. Now this would be a partial seizure if both of these EEG electrodes are on the same side of the head. So both of these are on the right. Okay, so that would be what an EEG might look like for a partial seizure. Okay, now I want to talk about seizures that can be either tonic-clonic versus absence seizures. And these have been defined primarily by their symptoms and manifestation. Previously, the tonic-clonic seizures have also been called the grand mal seizures. Now, these are generalized seizures, so they involve both hemispheres, and they're usually characterized by 5 different phases. There's the aura phase, in which a patient often gets a sense of dizziness or lightheadedness or fatigue, and may have intense emotions. Now, and then the next is the tonic phase. This can actually, the aura phase can be hours before the actual seizure. Actually, I said 5 phases. Now, we used to talk about 5 phases because we also included discussion of a premonition stage and a post-ictal stage. Actually, let me add in the premonition stage. And this does not happen in all patients. Premonition stage is can happen like a day before, and this is when sort of a patient just has a sense of deja vu or sense of foreboding that that a seizure may occur. An aura is more specific and causes physical symptoms like fatigue or dizziness, lightheadedness, and sometimes labile emotions. All right. The third stage would be the tonic stage, which only lasts for a couple of seconds, 2 to 3 seconds, and it involves sort of the tensing of all muscles, so they become very rigid because of the tensing of all muscles. And then there is the clonic stage, where the muscles tense and relax in quick succession. And then the 5th stage would be the post-ictal stage. Now, not all patients with tonic-clonic seizures are going to go through all 5 of these stages. Some may or may not have premonition or aura. Some may have just a tonic seizure. Some may have just a clonic seizure. But this is the classic 5 phases of the tonic-clonic seizure. Now, another type of generalized seizure that is possible is an absence seizure. Now, an absence seizure manifests itself very differently. Now, absence seizures are sort of characterized by a sudden impairment of consciousness, and so that's sort of the essential aspect of it. So, sudden impairment of consciousness, and it may be a complete loss of consciousness. Now, it's interesting because these can be they tend to be very transient. They tend to be shorter than tonic-clonic seizures, so they may only last 5 to 20 seconds. And sometimes people can be having an absence seizure. They can be sitting in a meeting and talking to someone, and sort of just start mumbling for a few seconds and then pick up where they left off, or they may stop talking altogether for a few seconds and then pick up where they left off. So that's not atypical. Now, absence seizures can have some overlap with tonic-clonic components. You can have sort of weak clonic components to it or weak tonic components, but they're really characterized by the sudden impairment of consciousness. So this is like the person's speech is slowed or interrupted. If they're walking, they may stand transfixed for a moment. The example that I think about is a neighbor of mine the absence seizures are very common in children, and a neighbor of mine was, draw a little picture of the story. He had a 5-year-old that was riding a bicycle, and he had his training wheels on it. And what he would do is he'd sort of ride along on his bicycle, and his parents kind of noticed that he would stop and stare blankly for a moment, for 10 seconds or so, and then he kept pedaling. So no big deal. The parents didn't think anything of it. They just thought he was stopping to think for a moment. But then, when he was like 6 years old, they took the training wheels off. And then what happened is the 6-year-old would be pedaling along, and he'd stop and stare for a moment. He'd stop pedaling, and the bike would fall over. Then the parents realized that there was something wrong. They took him to the doctor, and they did an EEG on him, and they found out that he was having, in fact, absence seizures. So, the absence seizures were pretty quick. They were like 5 to 10 seconds, so the parents didn't think anything of it until it caused him to start falling down on the bicycle, which isn't really normal behavior for a healthy 6-year-old. Absence seizures and tonic-clonic seizures are defined by their manifestations, but you can also see a difference in their EEG patterns. Tonic-clonic seizures have these very high amplitude, abrupt high amplitude waves, and absence seizures are defined by what is called a spike and wave pattern. If you look closely here, you can see this is a little spike. They almost, if you're looking at an EKG, they kind of remind me of pacer spikes, like these sudden spikes followed by a wave. This is characteristic of an absence seizure. Oh, here's a nice picture here. It just shows the pattern of placement of EEG leads. So you can see how they're spaced all around the scalp. And they actually take quite a long time to place. They have to place them with this special little cement to kind of glue it to the scalp. Okay, so interestingly enough, absence seizures are very common in children, and most of the time they actually dissipate over time. And that is because there is children have excitatory postsynaptic potentials that are developed much more quickly than the inhibitory postsynaptic potentials. So their brain is more easily excited than it is inhibited. There's sort of there's a natural imbalance with children, and this can kind of unmask other predisposing factors towards epilepsy, but as the excitatory and inhibitory postsynaptic potentials balance themselves as they mature, then the seizures can go away. So I believe it is in about 80% of children the absence seizures will dissipate by the time they get to adulthood. Okay. So you can see in the slides that I put up, I want to call your attention to again, back to the types of seizures, and I have another picture that can kind of draw your attention to this. So this here is a SPECT image of a seizure that is occurring. Now you can see in the red spot, this is like some hypermetabolic activity here. And this is where the seizure is beginning, and you can see it's off in the right hemisphere of the brain. So this is starting out as a partial seizure. All right, and it's growing in size and getting bigger. It's still a partial seizure because it's still on the right side, but now it crosses over to the left side just a little bit, and a little bit more to the left, a little bit more to the left, and now it has become a generalized seizure. And because it started out as a partial seizure and it became generalized, it is a secondary generalized seizure. Okay, so that just illustrates sort of the difference between so a partial seizure would sort of, again, begin on the right side, and it might spread around here, but it would never get to the left. So that would be a partial. And then this demonstrates the secondary generalized, and a primary generalized would start on both sides of the brain all at once. Okay. All right. So I wanted to talk about I wanted to talk briefly before I end this discussion of seizures about. So I wanted to talk about status epilepticus. Now, status epilepticus, if we had an EEG here, it would show either continuous seizing, so it could be continuous, that lasts for greater than 20 minutes. Now, there are some neurologists that don't like the 20-minute definition, so there has been some question that maybe this should be changed to 5 minutes. I believe that the standard is still considered 20 minutes, but with all sort of in treatment, most people think about 5 minutes. So whether you think it's anyways a seizure that is prolonged for either 5 to 20 minutes. So it could be a seizure that just continues, or it could be a seizure that sort of breaks and go to post-ictal state and then recurs again before it's fully recovered. So it can be either pattern, either continuous or intermittent without recovery. Now, we could have partial seizures that only involve two or three EEG leads in one hemisphere, or it could be generalized. And so this would be a generalized status epilepticus. Okay, so what's the big deal about status epilepticus? Well, it can be a life-threatening condition. So and the reason for this is when the brain is continually firing off action potentials, it's using a huge amount of ATP. So if you have a person with a generalized status epilepticus, the ATP use increases to up to 250% of normal. So you can quickly exhaust the ATP stores. And the other problem is you're also this can overtax the body's ability to provide adequate energy. So the body just can't keep up with providing glucose demand. So what's this going to do if this continues is you're going to end up with ischemia, because you're robbing the cells of energy, and very quickly the cells are going to die. So status epilepticus is a life-threatening condition because we're using up all the available ATP and glucose, and the body just does not have the capacity to deliver the sufficient supplies. So brain injury begins after 5 to 20 minutes, depending on which neurologist you listen to. So usually if we have status epilepticus, we will try to break it. So if a person is seizing for more than 3 or 4 minutes, we're going to give a medication like a benzo, or load them with Dilantin, or do something to break the seizure. Now, what do these medications do? They increase the inhibitory activity, or they decrease the excitatory activity. But sometimes the excitatory activity is so much greater than the inhibitory activity in the nerve cells that are causing problems that no matter how many medications we give them, we can't restore this balance. So sometimes people will have refractory seizures that no matter what combination of medications we give them, they continue to be in status. And I've seen this happen a few times, and the patients usually end up with significant brain injury and can sometimes die. Okay, so that is the end of the lecture on seizures, and I will continue with the next one talking about delirium.